Okay, let's go.
My
Let's
God.
go.
Big job
Right.
you have now.
Right, everybody go into Kahoot. Four, 4, 2, 1, 7, 2, 6.
Remember, the earlier you answer, the higher your score. Regina has been jumping forward, but the boys just overtake her. Let's see if a girl will win this time. Oh, Martha, you are not allowed to join the game. You know that.
No. I, of course, no, because sorry. Oh, look, that is is the rule of how you say when you do the exam, you cannot go yourself to one exam that you know the questions, no?
Yeah, you can't set your own question.
Where's everybody else? Like I said, again, there are 21 people online. Ah, okay.
Should we start?
Yeah.
Ready? Go.
I think BRUE is RC4, no? In the new curriculum.
Okay. Yeah, BRUE. Well, next. Again, Regina. Okay. Well, Regina is holding tight.
Booney's highest climber.
Highest climber. Ooh, that's anyway. Martha, you will tell us more about this when you're teaching, yeah?
Yeah.
Gradual on fire. Ooh. Ooh. So hope we get better after the teaching. Surab. Ooh.
Multi. Ooh.
Whew. We did very well. Mr. Boom. So 3. So Martha, you tell us more why 3 is wrong. Oh, Boone is not shaking. Have we come to the end? Oh, one more. Non-accidental injury.
Smoking.
Yeah. Hey, somebody said parent smoking. That's biased. Samia, no. Surev, and the champion. The BRUE. And we have Regina on the Sonda. Over to you, Marta.
All right, thank you, Marta. Please start.
Next time, Boone will see all the kids.
Oh my, well, oh my God, no, it's too much. Okay, now I just go to my presentation that is about that. When I see, I'm sorry, Boone, for that, because the curriculum now is, I think it's an RC4, no, that is BRUE, that goes now with the entity that is BRUE, no. Before was in the curriculum of acute life-threatening events. Is the same, but this is now they say they changed little bit about that, because even when you go to the research, they speak about I think ALTE, and now they change. And also in the research they don't change for BRUE. No, then what is BRUE? BRUE is a brief unexplained resolved events. And well, I'm going to introduce that when the parents go, normally with the infants to present with an acute event reported by the caregiver, and represent a wide range of patients with a diverse pathophysiology.
But I hope you know we are not seeing your slide.
You are not seeing? Oh my God. Let me see. How is possible? Because I didn't share, no?
You need to start sharing. You need to start sharing your screen.
Oh my God, just let me go. I'm sorry for that.
It's not voice activated.
No, you know, now to get out from the screen. Oh God.
Just click share screen.
Huh?
Share screen, click. You know how to do it here, so.
No.
Huh?
Oh, no. Wait a second. Wait. Don't put your screen there now. Then let me go to Zoom. I go to Zoom, sorry. Let me see. Now, I in Zoom and share screen. I'm sorry for that. Share screen now?
No.
Okay.
Oh, yes.
Okay. And just a second. I go to my PowerPoint. I'm sorry for that.
You have so many open.
Yeah, okay. Now, sorry. This is now, I think, now you see the screen, no?
Yeah.
Just a second. Okay. Acute life-threatening events. That is the as I tell you before. Let me see how I can go. Okay. Then, as I explained you brief, is unexplained events, resolved events. That is BRUE. And then the infants go to infants who present with an acute event reported by the caregiver, represent a wide range of patients with diverse pathophysiology. Then we must recognize, that means that we must recognize when is a BRUE, no? Because could be, there are so many differential diagnoses that we are going to see in a few minutes. And it's the challenge for the physicians, because is to identify those who are the risk of recurrence or having a serious underlying disorder, no? as I tell you, I don't know how I can take my toolbar from down because I cannot change the screen. Okay, BRUE is a brief, resolve, unexplained event. Why brief? Because it's lasting less than 1 minute, and is the strict age limit of under 1 year old. It's because it's briefed. Resolve. Patient return to the baseline state of health after the event. For example, they have normal observations, vital signs are absolutely right, or appearance because the fathers normally, when they describe the event, they tell us how it was, no? Unexplained, no explained by any identifiable medical condition. For example, we know the reflux, we know it happened because the reflux, or we know because the parents normally say how was the event, and also if it was nasal congestion, if they have some coryzal or something, no? Event, because it's more than one of the following. This event is characterized for one of these. Could be cyanosis or failure, or could be the child could be absent. Is a decrease of irregular breathing, marked change in tone, hypertonia or hypotonia, and altered responsiveness. That is the description that the parents give. Now here in this I see how the lips of this child is cyanotic, no, around. Normally the parents describe that, and for them it's very unpleasant event. No, BRUE is a description of an event, not a disease, entity in and of itself. Okay, the event has to have had a clear beginning and end, so has to resolve before presentation to hospital. Is this diagnosis of exclusion? Other cause should be considered in the history and examination. Any question at this point? The BRUE has replaced, as I tell you before, the term of ELTE, that is apparent life-threatening event. ELT is an old term for events that are characterized by some combination of apnea, color change, in muscle tone, or choking and gagging, and are very frightening for the observer. This term has been replaced and has described events that range from normal physiological events to pathological events, and so was not useful in determining diagnosis, treatment, or prognosis. Is because they changed this ELTE for BRUE, because that describes also pathological event, and BRUE is not really pathologic. You must has I say before is exclusion and diagnosis. Clinical history is very important for BRUE. BRUE is very important to have very good clinical history and should be taken from the parents or carer who witnessed the event. The general description to the event include, you must be sure that is if the parents tell that his child was choking, was gagging, was vomiting, if he was awake, asleep, or related breathing disorders including in that event. Position, if the baby was supine or prone, muscle tone, movements, respiratory effort, skin and lip color, duration and how it stops, and condition after event, and whether back to normal preceding the trauma and recent injury. Somebody can tell me how I can hide the tool down, because I cannot see my, oh my God, I jump. How I cannot see.
Click on the green button to enlarge your screen
Which green button?
at the top left.
Your screen sharing? No. Which one?
Oh, but it's okay. Don't worry. Just continue like this. We are okay.
It's because I just go to. You see,
Okay.
I cannot see my screen now.
Okay.
I just jump to the other, then I cannot.
You can press back arrow keys as well, Martha. Arrow
No,
key.
it's because I don't know where I press it now because I cannot make smaller my screen. I need to make little bit smaller. I don't know how.
Okay, look at the bottom right. You can see the TV sign. Click on the TV sign.
I just have one tool now.
Bottom right of your PowerPoint, you see a TV. See that small TV. Bottom right.
In which tool?
Bottom right of your PowerPoint.
I just have more.
No,
To be honest, Martha,
just
carry
continue.
on.
Yeah.
Carry on.
It's because I cannot see my screen.
Martha and Mrs. J has to take you for a lunch or something after this class.
Let me see. I'm sorry for that because I cannot see my screen. Then yeah, okay. How I made this screen smaller because I cannot see where I touch in the screen. How I can do?
Just continue
now.
Because of time.
Okay, sorry. Oh my God! Now I lose myself. Where is my? Which screen are you seeing now?
So your PowerPoint is, yeah, click on your PowerPoint. Yeah.
You'll have to drag it up.
You have to drag it up.
It's hiding now.
Wait. Zoom, can you take control of the, you can take control of this.
Yes, please. If somebody can take control from this and maybe let me help me with that because I just lose the button and I cannot change.
Zoom, you can take control of the slide for her so you can help her.
Who can? Boom.
I can't control your computer.
You are so expertise in that. Then maybe you.
I cannot control your computer though.
I think so. You can do.
No, I cannot control your computer.
Okay.
No.
Martha, just drag the, the PowerPoint.
Okay. Yes.
Drag it up.
Drag it up.
Yeah,
okay. Click and carry. Yeah.
Okay.
Now wait.
So enlarge.
You see, it's because I lose my screen down. I don't know how.
Martha, you keep
Okay.
slides
Now,
and
sorry
slides.
for that. Okay. Then I was here in that.
Yeah,
screen
you were on
with the
this
screen
slide.
I
Yeah,
use
you were on this
past
slide
history.
now.
Okay, the past medical history is very important, and then it's necessary to ask the mother and how was the gestational age. Infants younger than 44 weeks can have apnea of prematurity, and also how is perinatal history, including NICU and SCDU, and previous unexplained episodes or previous resuscitation also. Okay. Oh, Olu, thank you. Yeah. Okay. Yes, thank you, because you can help me to move. I give you, no? Okay. Yeah. And also previous unexplained episodes. If he has also the same, no, similar to the BRUE episodes, you must ask the mother, and also previous resuscitations. If the baby was in CRP or any event similar to that, or recent illness. Next one, Olu. Okay, no, before previous. Okay, yes, next. Okay, now a family history also is very important, because they can tell you about HUDI, or if it's any BRUE in siblings, and or any cardiac problem, including arrhythmias, or any parental consanguinity, or also social history, always you must consider is very important NAI. For example, if it's drug ingestion, if it's a factious illness, a suffocation, especially if there are multiple or changing versions of the history. For example, the parents, you must see how are the parents, how they tell the history, how they look when they tell the event. It's very important because sometimes they told the nurse one thing and then they go and tell different history to you, and then you must see also these two versions. You know, very important. Take a detailed so don't change. Olu. Okay, examination. Yeah, that is important because, for example, if it's a smoke or a smoking for parents, so if they have drug consumers, then you must know that very well. Okay, about the child examination, we start with the examination, and how is that? Must be full ABCD approach, assessment, consider differential diagnosis, and remember to test always capillary blood glucose, okay, because that is important to know, first of all, if the child is in something, in maybe in hypoglycemic or maybe different kind of illness. Full expose to child to check for bruising, bleeding from any nose, mouth, torn frenulum, and or subconjunctival hemorrhage. Plot weight and leg and head circumference is important because you can see also if it's in the head circumference is important, and that you can do that very quick. Not any dysmorphic features that indicate underlying congenital abnormalities. That is also important. You see that sometimes the mother didn't realize, and then you see this child is not normal, no? When you see the face, when you see the head. Okay. Then next one, Olu, and risk stratification and management. Well, it's very important to stratify in low risk, high risk. Okay, that is very important because low risk. Well, we have red flags in that presentation of BRUE. The child must be less than 60 days old, born at 32 weeks or 40 when you calculate, and also if it's more than one episode. Red flag also is abnormal history of examination, and unwell child also, because as I tell you, is the beginning and end of the presentation very quick. Okay, then if the child is unwell, significant past medical history, feeding difficulties, also family history, sudden death, for example, and social concerns. No, very, very careful with the NAI. Then low risk is no red flags, well child, when they appear and is well child. And high risk is any red flags, okay? Then low risk, serious pathology or recurrence unlikely, and you observe the child for 4 hours. That is what you must do when the parents are right there and the child is okay. Supposed to observe 1 to 4 hours, but we haven't got the time. I must say that the time to observe that for 4 hours. We can't tell that, but how many childs they come to A&E and then with just discharge in 1 hour, 1 hour and a half. And they say it's necessary to observe the child 1 to 4 hours to see how it's going. And always consider, I know the nurses doesn't want to do, but it's necessary to consider, very important, the BM, ECG, the guidelines, they say we must do ECG for all these children, and also the pertussis PCR, and I think we don't do that, no? Also shared decision making always, because you can ask, if you are not sure, you must ask the consultant, you must ask the senior, please, what do you think about that? And I'm going to take this decision to send the child home because this, and with early outpatient is necessary. Guidelines follow up in less, sometimes it's strange, they say less than 24 hours, and in some of them they say 48 hours, okay? But for me, 24 hours, because if something is wrong in 48 hours, that is 48 hours, is 3 days, is too long, is too much. if parents are confident also, because parents are very anxious when they go with the child to A&E. High risks need further assessment and investigation, and you must admit if you see any of these red flags, and treat any identified illness, and consider BM, ECG, and pertussis PCR. Next one. Olu? Hello. That is the next. Okay. Discharge advice that was in this, and discharge advice for parents and caregivers. Safe sleep, you know. I didn't know, so for me it's very funny. Lullaby trusts. Do you know before? I don't know if you will know before about lullaby trust. And also eliminating exposure to tobacco smoke. That is very important because many of them, they smoke, maybe not in front of the child, but all the clothes, all the things are impregnated with the smoke. And infants, it's very strange because, you know, normally you don't want to tell the parents, okay, you go home, but you do the basic life support to the child. They really get panicking. But at this point, I think the community must be involved in basic life support. Even if it's small things to start to do, you know, very, very, very slightly, but they must be trained about that. A specific advice never to shake the infant in effort to resuscitate them, because maybe many parents get very confused and they shake the child. Never. Just advice, never do that. And GP follow-up, you see, I put next 24, 48 hours, but I think for me is 24 hours is the 48 is too long. In my research was, I see both. Okay, next one. Olu? Oh, I tried to do myself. Hello. Oh, okay, I can see now. Olu? Olu? Okay. Lullaby trust.
I'm trying to change it.
Sorry. Lullaby trust. I see there are many, you know. I don't know if here in Doncaster we have one, but I have many trust houses, lullaby trust. I must check. I put one of them, but I see many of them, and there are many different lullaby advice. No, I take this because it was more I think more visible for your eyes, and always place give recommendation. And I don't know also if we have this recommendation. I don't think so in a pediatric. We must see in pediatric in our pediatric place. I don't think we have this. I'm going to check all the things to see if it make easy for us. And always place the baby in their bag to sleep, no in prono. Keep your the baby smoke. That is for the parents, of course, free during the pregnancy and after birth. Place the baby in the sleep separate. In separate small bed, you know, and then not in the bed with the parents. There are so many things that you must explain them before you discharge, because then also the parents go with more confident home with the baby. And I tell you, I have little bit problems with the parents when they go, because they say, oh, I go home and that's all, and you don't tell me nothing, why this happened and why this that, and you then it's very careful with this kind of situation also. And also when you have many lullabies trust, you can check many, because they, as I tell you, they give many different recommendations, and then you just can, and I'm going to be sure that in emergency we have one, and I never see that, believe me, to give to the parents, no. Okay, next one. Okay, differential diagnosis. Well, in this differential diagnosis, there are so many. We must go through many differential diagnoses. But I try to bring here, and I think I'm going to do very quick. I'm not going to go so long in that, but we must do the main thing. I did the main thing, and one of them is gastrointestinal. In the gastrointestinal, we must see and the main of gastrointestinal is gastroesophageal reflux, and is one of the common causes of symptoms similar to BRUE presentation, causing via laryngospasm. That is GER, no, GER, that is gastroesophageal reflux, and then the features from history that are suggested to GIR is an episode occurred with infant was awake and supine. That happened. That occurred during feeding for shortly after feeding. Regurgitation of vomiting in the time of the event, and obstructive apnea. The infant making respiratory effort but not breathing successful. I'm going to explain you a little bit about apnea, okay? Then that is the main thing that you see when is GI gastroesophageal reflux. Next one. Well, it's necessary to difference between GIR and GIRD. This one is gastroesophageal reflux, and the other is gastroesophageal reflux disease. Okay, that is diagnosed as that. Okay. Then the pathology. Somebody want to speak? Okay, no. Okay. Pathophysiology is most gastroesophageal reflux episodes are caused by transient relaxation. That is relaxation of the lower esophageal sphincter, triggered by postprandial gastric distension, and that is normal. Is because the child. I see some. I put some pictures here to you to just to check, and it's because the child vomiting so many times, because that is normal, no, for the child. However, GIR may also occur with normal lower esophageal sphincter pressure, if there is increased intra-abdominal pressure, or if there is delayed gastric emptying. Then we must be very careful in the exam when we examine the child abdomen. Okay, next one. No, previous gastroesophageal reflux. Gastroesophageal reflux normal and disease. When is the disease? Then the normal is common, affecting at least 40% of the infants. Approximately 25% of the infants regurgitate the milk or the feed 4 or more times, maybe 6-7 times a day. Usually begins before 8 weeks. Begins very important, before 8 weeks of age, and peaks at 4 months, and resolve by 1 year of age in majority of the cases. Doesn't not cause any crying or irritability in the healthy infants, and infant crying peaks at 6 or 8 weeks, and in some babies with simple gore may also be unsettled. No, that is because sometimes they unsettled is very important sign also for differential diagnosis. No, but after that they settle quite well. Rarely require investigation and can usually be managed with parental education, support, and anticipatory guidance. There are so many guidance. I think we must also. I'm going to be sure that we have some printed in the department, but because for that I didn't see, and parents also ask about that. You know, and they're very concerned about that when the child has many regurgitation many times during the day. And more when they have the BRUE episode. The disease. Hello, is somebody? Could you just silent because I thought you want to ask something. Refusal in the reflux disease is refusal to feed. They stop to. They don't want to eat. They don't want to. The parents sometimes say, "Oh, they don't want to recite. I just trying and then that and then." Very important to rule out the disease. Okay, pronounce irritability with feeding or excessive crying and gagging. Okay, sleep disturbances also, aspiration. Then the child could have pneumonia or previous pneumonia, or maybe infection, chest infection, maybe to us, they say, oh, my baby have 3 times in respiratory trouble in these months. Then you must be very concerned about that. Chronic cough, stridor, wheezy, epistotonos and torticolous. That is especially when they have some different syndrome. Okay, and that is and the Sandifer syndrome is the features of that is epistoton or torticolous is when the child has so long reflux, and then is so inflammation in the all esophageal. Then they start with this, and then they can diagnose this disease. Anyhow, I not get through very deeply because the time, and low, very important also that it is low weight gain. Then refusal to feed and no weight gain. Okay, and also maybe could be the possibility some hematemesis, the blood in the vomit. Okay, next one. Here is very quick. Just you don't need to learn this. I just want to share with you that is necessary. That is the algorithms about is 1 or 6 months of all with frequent vomiting. Then it's necessary to see that if any comorbidity or medical condition or any red flags, important to know. If that red flags no, then complication, of course, then no is no any complication. It's just gastroesophageal reflux, and then you can go if it's no any signs of GORD of disease. Then you go frequently unsettled behavior. Why is this unsettled behavior? Then we see also that we have some unsettled babies guidelines. Then we must check that. You know, it's necessary to do another teaching about that also, because unsettled child, no, and then we have already guidelines for unsettled child. What we can tell the parents, because parents very concerned about that when they go and they ask you. Okay, then also if it's not, it's unsettled child, because you must know the cause about, you must at least to advise the parents. Then like simple gastroesophageal reflux, then parental reassurance, support and education, advise general measures if required, you know, and provide gastroesophageal reflux leaflet. That I think we haven't got that in A&E, but we are going to work in that, I hope so. And then, yes, if it's yes, then we consider alternate diagnosis. Then you go through all this, then, or if no, if you see that they have disease, you must refer to pediatrics straight away, okay? Because the child has this BRUE episode. In top, he is diagnosed by disease. Then, and probably the parents tell he's under, for example, under lansoprazole or Gaviscon. You must ask that very, very tiny child has this medication already. Then you must refer to pediatrics. Next one. Oh, yes, I cannot change. You can change all. Okay. Okay, this, the other one. This is more or less the same. I'm not going to get about all this. It's all the, I put this here because you can see all, I am speaking about BRUE, about many things, and then you have in this, I find this very nice. Then I think you can remember many things with that algorithm slides. Okay, next one.
Is that your cat?
Huh? Yes, next one. No, sleep disorder breathing. You know, I put that because it's a sleep disorder breathing. It's one of the differential diagnosis, because what is that? What about sleep disorder breathing? Sleep disorder breathing is include disorder of breathing that affect airway patency. For example, obstructed sleep apnea syndrome, and also condition that can affect respiratory drive, that is central sleep disorder or central apnea. Of course, hypoventilation either has a direct central effect of peripheral muscle awareness. That means hypoventilation. Just a second, Olu. Hypoventilation can be caused because the muscle weakness, okay, could be peripheral or could be central, the hypoventilation. And remember, central is different. Central is affect respiratory drive, and obstructive apnea is I'm going to explain about obstructive apnea. Okay, then we go to the next one. Okay, I just do this because in that you can difference very nicely how you can see obstructive sleep apnea, obstructive hypopnea, and central sleep apnea. Obstructive sleep apnea, an obstructive event is one where respiratory effort continues in speed of reduction or cessation of airflow. Then airflow is there, but this respiratory effort is still there, but the airflow is the cessation of airflow. And obstructive apnea in children is scored if the event is associated with an absence of airflow that lasts for 2 or more missed breaths and is associated with maintained or increased inspiratory effort. Okay, and obstructive hypopnea described as giving more than 30% reduction in airflow signal and also lasts for 2 or more missed breaths with preservation of respiratory effort. Preservation of respiratory effort, that is important. Needs to be associated with physiological consequences, namely like arousal and also awakened or measure than 3% and fall measure than 3% fall in oxygen saturation. Then the saturation must fall down. Then must complete these 2 criteria to be obstructive hypopnea. And central sleep apnea is the event is associated with absent respiratory effort and absent or measure 90% reduction of airflow, lasting for 20 seconds duration or lasting for more than 2 missed breaths in associated with physiological consequences, arousal, awakening, measure more than 3% fall in saturation in infant or even bradycardic. Okay, a central hypopnea is scored when more than 30% reduction in airflow associated with physiological consequences. Then that is very important to differentiate the central apnea to the obstructive sleep apnea. That is, I'm going to give this presentation because that is very important. And I think with that you clarify, me, when I was doing the teaching, I clarified so many things also. And then is in the last research, okay, doing by, just next one, look. You see, they doing by this, that is capnography. I cannot see, let me see if I can move a little bit up.
Martha, how much more do you have? Because a lot of people have to start shift at 12 o'clock, you see. I know you started a bit late, I'm sorry, but how much more do you have?
Okay.
Do you want to focus on the important things?
Here we have the etiology of the central apnea or the other, that is, okay, you have very brief obesity, tonsils, adenoids, obstructive apnea, and here is the central apnea, the etiology, okay, central hypoventilation disorders, immaturity of respiratory control, okay, and let's go next one. And the treatment for that, the apnea could be surgical because if they have, for example, adenoids or they have tonsils, very hypertrophic tonsils, also respiratory support, for example, when it's very bad, they need the CPAP. Anti-inflammatories can help. Also airway adjuncts, also medication that we are not going through, and in some of them you can give oxygen. Next one. Next one, Olu. Hello, Olu. Okay, and okay, that is very quick. Is breath holding. Breath holding babies. The breath holding is when the baby or child stop to breathe for up 1 minute and maybe faint. And it can happen when the child is frightened, upset, angry, or sudden shock or pain, okay? And it's usually harmless, but can be scared very scared for the parents, and they go to a Yannick absolutely out of tone, you know, particularly when it happened for the first time. Next one, please. During the breath holding, the child may be cry or be in silence and holding the breath open. Also can open her mouth and going to cry, but make no any sound, turn blue or gray, be floppy or stiff, or their body may jerk. And faint, could be also faint for 1 or 2 minutes, okay? The child may be asleep or confused or confused for a while after that, okay? Next one. And the breath holding are not epileptic seizures. And the recommendation to the fathers, like the child on the side, no pick up them. Make sure that they cannot hit, they're not going to hit the head, the arms or the legs, and reassure that the child rests enough afterwards, after this episode. Okay, next one. Cause of breathing holding. Well, there are triggers sudden for shock, as I tell you, pain, emotion like fear, upset, or anger. Okay, there are 2 types of breathing holding. Blue breath holding spells. That is most common type of breath holding and happen when child's breathing pattern changes, and they can the parents explain that. And reflex and seizures. We are not going to get through that, because that is another subject. Then it's absolutely, and the child normally is diagnosed after that. And normally when this happen, also you send the child for the first shift. Okay, if you are unsure, or you can have to pathways about this. Okay, about reflex and seizures. Okay. And then go to the next. I'm sorry for that, because another differential diagnosis could be, for example, central nervous system, could be head injury, epilepsy, structure. Also, you must be very concerned about inflicted injury, drug ingestion, suffocation, surgical also, acute gastrointestinal obstruction. Remember, the abdomen is distended, and then push up, and then give also these kind of things like apnea and like all BRUE. Okay, then you must just rule out that is nothing of this. Psychological, transient choking or gagging. Cardiac, you must be sure that is no congenital heart disease, arrhythmia, prolonged QTs, because you must do the ECG. Okay, airway obstruction, including inhaled foreign body, or laryngomalacia, all the things. And I need to finish. Next one. Reference, all these reference, and still more. And next one. Sorry for that. It was
finished, is it? Thank you.
Thank you very much, Martha.
Yeah, Martha. I think we have quite a bit of sidetracking, because the presentation has to be like a BRUE, and then differential diagnosis just mentioning this. Now, there are a couple of announcements we made. Safety flash, RCAM. Have somebody got this meningitis? No.
Yeah, it's because I say must be no, because if we go back to that, it's necessary.
That's great. No, the safety flash from RCAM about meningitis. Has people received that? But we have received it, is it? So meningitis cases are going to increase in winter. So the common symptom, they say, is a high temperature, limb pain, and cold feet and hand. So these are the early sign, and we should be mindful if somebody presented like that. The second announcement is the middle grade charter writing. I don't know whether Zia is still in attendance. Zia, is Zia around? No. I think we need to write middle grade charter, please. Yeah, in liaison with the degree training.
Yeah, there are so many things. I already, when I start to do many things, still show that the doctors, I don't know if the doctors are agree with me, but it's like a nurse, no, doctor must be in control of the situation of the child, because you discharge the child and you are responsible for that. Then no, it's necessary, doctor, because sometimes you say the nurse, oh, the child is okay, don't worry. No, you must be sure that that is that. and the child is self-discharged. Then there are so many things that is necessary to do in the department.
Yeah, but Martha, one of the important, I suppose, there's so many different potential reasons why a child could have BRUE, and within the ED, I suspect our main role is to recognize the child has had an episode.
Yes, of course.
And therefore, do not discharge them, but actually refer them to the pediatrics for further investigation of what happened.
Absolutely. Yeah, absolutely.
Yeah. So I think that's probably the most important message for and lesson for BRUE, which is actually how do you recognize a child has had BRUE, and in reality, all the various potential reasons why the child could have BRUE is probably less critical for us, more critical for the pediatricians, but less critical for us to know in detail. But the most important thing is to recognize when a child is presenting. That's the one.
This is very nice one that you must keep in mind. You keep in mind.
Yeah. Martha, I think that's probably the take-home slide, isn't it, for today?
Yes.
You know, of all the slides that you've put together, which is a lot of facts, this is probably the key one.
Yeah.
It's like a TIA, is it? It's like a TIA. So BRUE is like a TIA, children TIA, you know. So manager as TIA.
Yeah. So shall we close the thing with the Kahoot again?
Yeah, I think I have to leave to join the.
Okay, Mr. J, thank you very much for
thanks guys. Martha, well done.
for being with us today.
Oh, thank you very much. Thanks.
We'll close. We'll finish off this session with the Kahoot again, the Kahoot games, and then it's 12 o'clock. It's just that a lot of people start work at 12. You see.
Okay,
Yeah.
I just
right. Olu, go.
Olu can always drive in my screen. Then I think, or you can drive. You can drive my screen and take out this or what?
No, you have to
close.
You have to stop sharing.
Okay, stop sharing. Stop now. Okay. Oh, it's nice to see you there.
Okay, 8880416. Let's go.
I think it's only been 9 people doing it, so I'm going to start. Yeah.
Yeah. Let's go. Let's go.
Wow. That's
very good. They improve. No.
Much better. Yeah.
Hope.
Still improve.
Yes, still.
Rochi, let's hope Regina wins this time. Yes.
Oh,
Fantastic. Don't forget NG feed. We don't do the nurses will help you to do the NG feeding if you ask them.
Yeah.
Oh, Prajwal, and then Boone is on fire again. Okay, what is the red one? What is that one? 10 months old, previously were now drowsy and floppy after a nap. Martha, what's that one?
Sorry?
The red one. 10 months old, previously were now drowsy and floppy after a nap. What's that one? I know the blue one is a febrile convulsion. The yellow one is a head injury. Anyway, let's go on. Prajwal still on top. Okay. Multi-select, you have more than one answer.
Oh, yeah. In one day, I think.
Yeah. So the yellow one, born at, not born less. So 37 weeks is okay. It's not less than 37 weeks, yeah? The Boone. Regina, come on, I want you to eat it. You need to get Boone out of there. Wow, fantastic. Excellent. Well done.
Good.
Ooh, Mr. Boone doesn't want to leave the place. I think it's the last question. Let's see if Mr. Boone maintains his lead. Come on, guy, Regina.
Regina is very good.
Yeah. Whoa.
What is that?
So let's see who the winner is. And the winner, third position, Regina. Surev. And the champion of the BRUE.
Oh,
Fantastic. Samia and Prajwal. Well done, everybody. Thank you.
All right, that closes our session for today. Thank you very much, everybody, for taking part and for attending. Please remember to fill in the feedback form for every session. So for every session you do the feedback, you get a certificate. No feedback, no certificate. And you need to identify yourself with your email address.
Yeah. I see Regina is very happy. There's something making her very happy. I know. Yes. How's your husband, Regina? Say, extend our greetings to him. All right. Extend our greetings to him.
And I suppose it's good to see our fellow colleagues from Nepal attending for the first time today.
Oh yeah.
We'll hope to see you guys regularly all the time now from now on.
Fantastic, yes.
And when are you guys coming over to UK? Is it in 3 months or 4 months? Soon anyway, aren't you?
In 2 months.
Ah, okay, very good. Okay, I think we will close the meeting for today. Thank you very much, and we'll see you guys next week.
okay. Thank you.